be having a connection with society. North India, consanguinity is largely unheard of. Whereas South, consanguinity is a norm rather than an exception. So there is a belief here that, if you get married to your cousin, then it's somebody who is known to you, and the wealth remains in the family. And paradoxically, scientifically, the genome pool also remains in the family. There's no sharing of the genome pool. So what happens is the same autosomal recessive conditions, which were otherwise well behaved and recessive and not expressing, get expressed because they found a like-minded partner in another cousin who is actually the same.
I will not take much of that.
Sure, sir. I don't have to.
Thank you.
Thank you, sir. I'm here the country, then I got later to the media understanding.
No, morning farming.
No problem. Thank you so much. Thank you.
Where we want them.
Yes,
There.
yes.
Okay, on we have to give them.
Sure, sure. Thank you so much, sir. So, this history is very important because it will help you a lot in solving a lot of cases. You know that taking a history is a lot like being a CBI officer, okay? Being there on the scene of crime and collecting telltale evidences of crime. So you have to have a very interrogative mind. You have to have a very imperative mind, and you need to have a very analytical mind. Because the patient is telling you the diagnosis, but in a way that he or she understands. So nobody's going to come and tell you, I have cerebellar ataxia. Okay? Or nobody's going to come and tell you that I have a progressive regression. Nobody's going to come and tell you that I have a neurodegenerative gray matter or a white matter. So what happens is patient is generally trying to tell you something, but you need to take only as much as you want and tweak the rest of it. Okay? Because the mom may not be sure what exactly you want from her. For example, simple thing I'll tell you is, suppose somebody is, they go to the schema of examination, but I'm just giving you some random, cues here and there. For example, you ask the child to come to you, status into the ICU, PICU. So by rule, when somebody comes to the PICU, you're not spending a lot of time taking a detailed history. That is an exception where you're not spending a lot of time. Where you're taking a detailed history, there you have to do emergency management. Okay, you remember we talked about triage last time, right? We talked of common sense, we talked of medical sense, and then we talked of specialty sense. So it is very important that you know where you are, right? Suppose you are in the ICU, then you're just doing what you need to do at that point of time. Yes, you will take a very short history. For example, somebody has come to you with acute onset of vomiting and altered sensorium. Okay, so then you want to ask history like any envenomations are there, or any poisoning is there, or any kind of intake of drugs is there. That is a kind of short history that you need to take. But then while you're taking that history, one person is focusing on the ABCD. Okay. But in general, in medicine, and especially so in neurology, history is very, 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 very good. In fact, there are some diseases like epilepsy, where it is a historical or a clinical diagnosis, right? It is very seldom a EEG or an MRI diagnosis, definitely not an MRI diagnosis, right? Very few situations where MRI will help in typifying your epilepsy. Yes, there are. It's not that there aren't, but it is primarily a clinical diagnosis. Similarly, with asthma, which you have a respiratory system, there is hardly anything in your investigations which will tell you about asthma. It is not that the child comes to you with acute severe asthma, you do an investigation, okay? You have your PEFR, your peak flow, you have your pulmonary function test and all that stuff. But it's just giving you a surrogate for that, but not a diagnostic of the. So it is history and history. So that it is simply what it is story. Okay, that's not word meaning of history, but that's just me paraphrasing. It is the patient's story. So when you get a patient who has come to you, first thing you have to ensure is ensure whose presence with the child, ensure the presence of the parents and definitely the mom. Okay, insist that the mom is present there, and if possible, if the dad is also present, is going to be helpful. Because in many situations, situations like, for example, mom has recently delivered a kid, and somebody else has brought the child. Or the child is growing up with grandparents. The child is growing up with an uncle or aunt, and they might get it. But the thing is, the timelines are different. Suppose you have a neonate, you definitely need the mom because she needs, if you want to get history of her pregnancy, her previous pregnancies, her abortions, and still stuff like that. Suppose it is an adolescent child, maybe 17 or 18 years old, then probably if it's okay if the mom is not there, the child is related history. If there is no relevant past or birth history. That is why it is very, very important that you insist that the parents be present with the kid when the child has come to you for many reasons. One, the reliability is poor with other family members. So they are not very observant, and the only person who is spending a lot of time with the child is the mother. In the most situations, there are exceptions when the child is staying with a grandmother or somebody else. Now, what though in families or in situations where children are orphans or in foster care or staying in hostels where the parents are not really available, right? That's not an excuse for not trying to get a history. Even if they are orphan children, all their birth records will be there in a file in the orphanages, right? So, if you have an orphan child, insist for the caretaker get your file from the orphanage. So now you don't have any private orphanage. All of them are government orphanages, and they are supposed to maintain the records. And most of the time, these are the children will be retrieved at the neonatal period, and there will be a good neonatal school. But if the child has been adopted or taken to the orphanage a bit later, then it might be a challenge because we do not have any idea about what was the perinatal or neonatal history in the child. Okay? But still, we will try to find a way of getting what we might by searching for other markers in the examination, right? So, starting with the name, I know that there is a little bit of repetition that overlap from the last time. Starting with the name. So, one thing you should remember, what pain is on nuances. A simple nuances in your examination, which some of might say or not, and mostly derived out of these videos. Suppose a child is to be addressed. Remember that the child is the reason why we are doing it. So whatever we do has to involve the child in the conversation, especially if it's the child who is about 3 years of age. Okay. So generally, children above 3 years of age are able to give some amount of history. May not be very accurate history. Children these days are very intelligent. They will tell you, for example, I had a 4.5-year-old child who successfully described his headache. When he said that headache is headache, he said it's around this side or this comes here, and then I have a blurry vision, I can't see much, my toys don't look right, I feel like I'm going to puke everything. You know, they will come with that history because many times what happens is the parents themselves may not have asked so much of detail at home. The child must have said, okay, I have a headache, so I'm going to come, I sort of go to the doctor, the mom or the dad, but straight away vision. Or the child can be very specific and the parents may have asked every single detail and then they must have had all the information that you wanted them. So ask the mom, ask the child if the child is about 3 years of age and work with them. And that is where you get a lot of information. Now, you need to strike a rapport with the child. It's very important. And ask what the child is called at home. For example, if somebody is called Sakre, and then his official name is Sakre, but how somebody is calling him before, right? And you keep saying starting, and the guy does not respond. Because his name is only on the birth certificate is starting, but everybody calls him Ulu. So what happens is all this child is not responding to me. He's not hearing well, he's not responding well, he's not taking eye contact, so I'm going to draw my conclusions and say, all right, this is the child who is not having a social connection. Especially children who come to me with us with developmental language delay, no joint attention, no procedural pointing, no eye contact, no social connect. What is this? Yes. So it is autism spectrum disorder. It's very important, these minor things which are important. But if you call it solo, it will make it term. Okay. So it's important to ask what the child is called at birth and call his similarly and see how he responds. But children don't always respond to failures. Okay. Okay, just cover my bad to student attention. So what happens is when you see this child walking into your room with his parents, family thoughts. So if you have a child who's come with his parents, the way he behaves with his parents is also a representation of his personality. Okay? He doesn't, you don't have to, immediately jump to see how he behaves with you. Well, some children may be very shy, some children may be very expressive, they have no stranger anxiety, they just mix with people and they come out. Some children may need to be cajoled and coaxed, to talk to them. So ask them things like, what do you have today morning? What is your favorite meal? And then say that, oh, I see something in your tummy. Is this what you ate in the morning? It is pointing out to all funny kind of things and try to establish a rapport with the child. And it works very well, believe me. When you need time. It's not that they rush into your clinic and then you say, what is this? What are you? What is your name? What is the usual thing? Suppose it's a 3.5-year-old kid. The child will just tightly hold mommy's breast and look towards mommy and get very scared at the doctor. Generally, most children dislike doctors and hospitals. Remember your childhood where you would go into hospital and all you could smell was phenol and Dettol and all that kind of, hospital kind of odor. Which is what children don't like. Nobody comes to a hospital by choice. Okay, but especially a child who has received vaccination jabs, especially a child who has been admitted in the hospital. So you must keep all this in your account. So is the child having normal stranger anxiety, or the child is having excessive stranger anxiety, or the child is kind of petrified with your very presence? That also will give you a lot of information, right? And you have the luxury of, if the child is extremely uncooperative and absolutely not allowing you for examination, then what you can do is, of course, the environment that you need to have in your clinic is that of a very congenial environment for children, which is what is recommended. So you have colorful walls and you have toys, and I don't think there's any pediatric clinic without that. So you have toys and you have balls and you have a horse on which the child can play, or some balls or kind of activities that the child wants to do. So send the child back. If you feel that this is going to hamper your examination or your history taking, then send the child back outside and say, let him play around for a while and then get accustomed and then come back. It has happened like that many times. Just yesterday, I had this child who was 5 years, 7 months old. And he was referred to by a pediatrician for some paroxysmal events. And then I asked the parents, what are the events like? And they said the events are like the child, does this and then it holds his mouth like this. Right? And then he is doing that about 10 to 15 times every day. He went to a pediatrician and he went to a pediatrician and then the pediatrician said, okay, this is epilepsy. You have to get an EEG done. Remember that EEG is only an extension of clinical examination. So got an EEG done. EEG is showing some frontocentral sharp waves. So the epileptologist or the EEG specialist, whoever, has reported it as protocentral shock waves, probably abnormal EEG. So now the pediatrician felt that, okay, it's an abnormal EEG, there are some movements. So I'm going to kind of, start an anti-epileptic. We started the child on an anti-epileptic, and for a week, this went on, and actually these events went on increasing. And then the second week, the parents were not happy, so they went back to the pediatrician. The pediatrician started the child on the second anti-epileptic drug. Even after another week of starting the second anti-epileptic drugs, the symptoms did not subside. So that is when the child was referred to us, and then the moment the history was taken, I said, "Do you have any videos?" Then Dad said that the moment we take the mobile to take a video, the event has aborted. It's just not possible for us to take a video of that event. So I said, okay, fine. I tried talking to the kid. The kid was very resistant, just did not open his mouth, no matter what I did. I have a toy which repeats what the child says. I call it the ukulele child toy. Okay, there's a parrot. You press it and you say hi, and it says hi, hi. Like that kind of thing. So all kinds of those toys which are there. I did everything possible on the earth, but he was just so relentless in his thing. So I said, do you mind going out and playing for a while and come, and then we'll be friends again. So I sent the family out, and then called them back again after another 1 or 2 patients. They came inside by then, the child was a little familiarized. And I said, see, I came to know from my secret thing that you had idli this morning. Tell me how many idlis you ate. Because I asked the parents. And he said, I ate 2 idlis. And then I said, no, but I am seeing 6 idlis in your tummy. He said, no, there are 2. Okay, so what happens is ultimately you do something and you get him into your conversation. Then he said, you know what, when you were doing that thing, one of the idli came out of your eye. He said, where? And I said, you show me, then I will tell you where it came from. Then he showed what he did. So that is called suggestibility. Okay, that is called suggestibility. Suggestibility is the classical feature of a non-epileptic psychogenic event. Suggestibility means, for example, a child comes and you tell the child, okay, can you show me what happens? Generally, if it is a true seizure, the child will not be able to show that. Okay, unless the child is very intelligent and people have been talking about it all the time in the house, but then he won't be able to exactly enact that. But the description of the parents was exactly matching the description that this child did in front of me. So, first of all, when the parents were describing, they were not describing anything which was fitting into any kind of epilepsy, right? Happening 10 to 15 times per day, always occurs during the day, never occurs during the night time, always occurs when the family is around. Okay? So, and another thing you should remember is what time of the year these events are occurring. You will see that in holidays, the non-epileptic events are very low. Okay? Whereas in the first 3 months after school, you get a barrage of non-epileptic events. You should see that pattern. Okay? So these are the things you should always keep in mind when you are taking history. And then these are also the problems which when they are closer to board exams. Migraines peak at the time of board exams. Migraines peak at the time of assessments, right? Especially in 10th standard and 12th standard children. Migraines are an all-time high, especially now with a lot of screen use. So this boy was a typical case of non-epileptic psychogenic event. Now, what will you ask a 4.5, 5-year-old child doing this? You won't even think of that. You will say, oh, he's too young, to do all that. And then I sent the child out and I talked to the parents. I said, how is the child generally? Then they said, he's very intelligent, very observant. So what are the things he does at home? Tell me some fun things that he does at home. Then he says, you guys better listen to me. If you don't listen to me, then I'm going to board a bus and you all are going to sit searching for me and have fun that day in the bus. Imagine, this was what the child used to speak. So you see the intellect of that child, who is capable of doing something like this. So then you dig deeper, and then go about, if anything happened in the past, has anything upset him in the school, in the house? No, nothing, any bereavements, any deaths in the family, anything that has, caused him any distress. And he says, no, there's one thing that he's always at loggerheads with his elder brother. And the other day, the elder brother got some dress and this guy didn't get. Now I can see that since then this problem has started. Right? So simple things, you can't imagine the kind of stories that people have to say. So this is history. This is the level you have to go. Otherwise, what would I have done? Okay, let me get a repeat EEG done. Let me add a third anti-epileptic. It will never go because it is not epilepsy at all in the first place. Right? So this is very important for you to do. Second part is covered, age. So age, you have to know what age, what diseases are common. Okay, so the rough idea of that is very important. In general, to tell you, see, thyroid issues, they are more common in adolescent females, right? And then acute glomerulonephritis, more common in 5 to 15-year-old age group. Infantile hypertrophic pyloric stenosis, more common in, or usually seen in, say about unusual setting is a 6 weeks old male infant. So this is the kind of, setting that you must remember to diagnose a particular disease. So when you read it in your textbook or your marrow or prep ladder or whatever you are reading, make a note of everything that is given. Everything has some information. So somebody says, oh, age group is who is going to remember all the age groups? It's quite boring sometimes. That's what you feel. But actually, it is very helpful. Having said that, it does not mean that it can never occur beyond that age group. I told you last time that there is never and always in medicine. There are always exceptions, which are called as contrast. Okay, so they are not typical textbook explanation, and they can be either away or very close to that. For example, nephrotic syndrome. You don't see it generally in infancy. You have an infant who has got a lot of edema. Thinking of other causes, you're not thinking of nephrotic syndrome as your first diagnosis. But that does not mean that nephrotic syndrome never occurs in infancy. It can occur, but you will think of common things first, right? So don't be lured by fancy diagnosis. Don't be lured by, feeling ecstatic that you have made a very, novel and very stylish looking diagnosis. I know that undergraduates come and say, oh, I saw a case of Cornelia de Lange syndrome. Okay, and then you're thinking of what is Ophelia syndrome then. It is quite enticing, The whole medicine is like literature. It's like a story. There is Cornelia and there is Ophelia. I'm not making up anything, right? So Ophelia syndrome is, Shakespeare, right? Have you read Shakespeare's Ophelia? Have you read that novel, Ophelia? No? She's a kind of witch. What have you read then? Okay. So Ophelia syndrome is, you see a condition called, it's a paraneoplastic syndrome where you will see that the child has got some kind of different Alice in Wonderland kind of. Alice in Wonderland syndrome also is there, okay, in medicine. So it is, you should try to create some interest in the ordinary. For example, you are seeing something which is looking, somebody will tell you some textbook description of something. Like we talked about last time, said this is leprechaunism. Then you Google who's a leprechaun? He's an Irish dwarf, okay? And then somebody says this person has got a cherubic facies. Cherub, okay? Cherub is, who is a cherub? C-H-E-R-U-B. You've seen those old vintage medieval European buildings where there's a baby with wings like this. So that's a cherub, right? So a cherubic facies is a baby-like facies, like this, which is a moon facies sometimes, which you see in Cushing syndrome. So it is what you add value to your knowledge that makes it interesting. Read about it. You have resources to that. So age group is very important. Now, for example, I'll give you one simple disease, which is like, very easy to diagnose in neurology. It is called mineralizing angiopathy of lenticulostriate vessels. The name looks very long, but it's actually a very simple disease. Very common in children between 1.5 to 2 years of age group. Child has very typical history, virtually the child patient is narrating the history, you're sitting at the other end of the table, and then you're having a laugh of your child because you've already made your diagnosis. Some diseases are like that. Very simple. The patient is as if he is just paraphrasing the textbook that you have read. The typical setting is an infant who was crawling, had a very trivial fall. Remember, I'm using an adjective here. He had a very trivial fall. And then he went to bed. He woke up next morning, and when he cried, there was deviation of angle of mouth towards one side. And he was unable to get up from his lying down position. And when mom tried to give him a cookie, he was not using his usual right hand. He was using the left hand and crossing the midline. Okay? So this history is very typical of arterial ischemic stroke due to mineralizing angiopathy of the lenticulostriate vessels. Quite a common cause of stroke in India, not in Western world, right? So this you will know only when you ask the history. So when you ask the family might come with hundreds of complaints. One thing the mother may say, she may only be worried about the face deviating, and she may not have noticed the right sided disease. Okay, or she may be worried that the child only had a fall, and because of the fall, the child has injured some nerve which has caused this face problem. Or some of them may develop a seizure episode. Or she's only worried that the child did gotilla, but when he could not get up in the morning, that may be her only complaint. Remember, it is not easy to get history from infants. Okay, an older child who is going to school, suppose he has deterioration in his handwriting, then it will be diagnosed, it will be picked up very early. Because a teacher will tell this is a child with good handwriting. Now the child is having a bad handwriting, right? So when there is a deterioration in his handwriting, that will be picked up. But an infant who is still ambidextrous, who has not developed handedness, right? That is why I was waiting if anybody will pick what I am telling. I said he is an infant. And I said he is not taking cookie from his usual right hand. Was I right when I said that? Was I right or no? Yes or no? Am I right when I say that that infant was usually right-handed? Why? It's stand up and tell. It's okay. Why? Why? What is that called? Not, you're right, you're nearly there. So it is handedness. Okay. So different books give, and time of handedness is different. Usually it is about 3 years. So 2 to 3 years, different books give different interpretation of handedness. Some people even say 4 years, but it's not that late. Generally about 3 years. So suppose the mother is telling my child is usually taking everything with his right hand. When you ask him, and then he has a seizure, then I am thinking whether this is related to his hand preference. Now there's a difference between hand preference and handedness. Okay? Handedness is a normal physiological achievement where one side of my brain is dominant, so the opposite side of that brain is dominant. So generally, my right hand, most of us are right-handed, and my left brain is the dominant one, and the right-handed is the my-handedness. Unless, especially in India, unless I was left-handed to start with, but my parents forced me to be right-handed. Remember this also in the history. Okay, in the Western world, generally they are not, obsessed with left or right. But in India, we are obsessed. The right thing should be done with the right hand. Is what people think. Culturally, we are like that. So you see how every detail we have to ask in the history. Why I am telling you all these minor things? They're all stemming from my experience. All of us, if you ask, sir will have something to say, sir will have something to say. They're all things that you learn from your experience. So if you just ask, okay, how is your child having a hand preference? Mother says, no, he writes everything with his right hand. Okay, he writes everything with his right hand. But for the rest of the activities, which hand does he use? Ah, yes, doctor. He used to do with left only. I hit him nicely and made him write with right hand now. Now he writes with right hand. So this guy he's a left-handed guy. He was forced to be a right-handed guy. Okay, so this is also possible. That is important in your handedness to know which is the dominant hemisphere, especially when you have your strokes. So I was talking of handedness and hand preference. So handedness is what you achieve normally. Hand preference is what you behave abnormally. Hand preference means a child, for example, say had perinatal stroke. Right? Either in his perinatal period is, what is the perinatal period? After a while, we're going to play a Bollywood song where you have to shake and dance and see that your myasthenic eyelids will be lifted up. Yeah? What is perinatal period? Now, a little before birth. It is not prenatal, it is peri. Peri is around. Okay? Just like, Raju sir is and Sesssion sir and me are around you, hovering around you, and you're feeling so uncomfortable. Being forced on a Sunday morning to listen to a neurology class. Okay? Peri, 28 weeks of gestation to 1 week after birth, right? So during this period, when there is a stroke, it is called perinatal stroke, and many a times these are missed. They are not picked up. So what will happen is the child develops early handedness, which is called as hand preference. So suppose a child starts having a preference for using one hand before his expected time of handedness, then we call him as somebody who is having a hand preference. Please don't confuse this with hand regard. Okay, so hand regard is another milestone. By 3 to 4 months of age, the child will be looking at his hands like this and laughing. Okay, have you seen infants? They'll be, looking like this at their hands and they're laughing and smiling. That is called as hand regard. And when there is excessive hand regard and beyond that time, that is also abnormal. Okay, they will also have feet or heel regard. They will hold, child pose. When you are doing yoga, there is a child pose. You're sleeping and then you're holding your feet. So they will look at their feet also and smile. Right? That is called as heel regard or feet regard. So these are the different milestones that children develop. So it is important to ask for this in your history. So you have your name, you have your age, gender is important. Okay? Always ask the gender. Simple as it may look, especially neonates, nobody bothers to ask because they don't have a name yet. The baby of somebody. The best way to describe a neonatal case is male baby of so and so, female baby of so and so. Because again, based on what is the gender, you are looking at various factors, right? For example, some X-linked dominant conditions when they are there, right? Can you name some X-linked dominant conditions? Is that too much for you? I'll leave it to you for homework, right? It's worthwhile to know which are the X-linked dominant conditions and X-linked recessive condition. Okay, name one X-linked recessive condition. Very popular. X-linked recessive. This is where we have POC 1 and 2 now. Don't tell me you need to be a doctor to know this. Huh? Not thalassemia. Doesn't of thalassemia. Color blindness, yes. Hemophilia. So X-linked recessive conditions are seen only in males. Okay. unless it is a Turner's or there is some lyophilization that has happened, and you can then see them in females, right? Whereas X-linked dominant conditions are generally fatal in males. They will not be able to survive. Simple it is, no, males have only one X chromosome, right? If there is a disease in that X chromosome, there is no other X chromosome to compensate for that. So you should remember that way. Don't try to memorize anything by rote. Understand? XY in male. So X is dominant anmele, the disease is going to be dominant. They are not going to survive. Whereas in females, even if one X is dominant, the other X is there to compensate. So they will express. So a typical feature of X-linked, the typical condition X-linked dominant is incontinential pigmentation. You have these words and all that. Can't diagnose it in a male child. Generally, they are female. And the Zeccardi syndrome. There are many conditions. Okay. So, mainly skinky hair disease. Many conditions are there which have got this kind of inheritance. Now, you know what is the importance of knowing which disease, what is the mode of inheritance, autosomal recessive diseases, autosomal dominant diseases. Why is it important to know? When we come to family history, we'll discuss about that. Why it is worthwhile to remember which diseases are autosomal recessive, which diseases are autosomal dominant, which diseases are X-linked dominant, which diseases are X-linked recessive, and which diseases are usually spontaneous mutations, which do not have a Mendelian pattern of inheritance. For example, Sturge-Weber syndrome. Sturge-Weber syndrome generally are spontaneous in mutations. Okay, so you will not do a genetic diagnosis there because it is highly unlikely that it will recur in the same family. Same is with progeria. Unlikely that it will recur in the family. They're usually spontaneous mutations. Whereas other diseases, your thalassemia, it is autosomal recessive. Hereditary spherocytosis is autosomal dominant. Okay. Similarly, it is important to know in the same group of diseases, the mode of inheritance is different. So, can you give one example where there are a group of diseases and the mode of inheritance is different? Have you heard of mucopolysaccharidosis? Okay, there are at least 6 to 7 types of mucopolysaccharidosis. So, type 1 is Hurler. Okay, then you have Hunter. Hunter is X-linked, whereas the others are recessive. So it is important. Why it is important to know? Because you have to predict the recurrence risk. Okay, and why is it important to know whether a particular disease is autosomal dominant? Because autosomal dominants have got vertical transmission. So usually autosomal dominant andre one of the parent is having that disease. Okay. Whereas autosomal recessive is both the parents are asymptomatic. Whereas child in the horizontal line there will be disease. There will be cousins and sisters, brothers, siblings having the disease. So if you see that pattern, you can guess that this is this disease. So somebody comes to you with 2 affected siblings, 3 affected siblings in the same family, it is likely to be autosomal recessive with the parents being normal. Okay. Whereas if the father or mother is having that and the child also has that, then you will start thinking it is dominant. Now there is another disease which can occur vertically, which only occurs again in males. Which is that? Very few diseases we have to remember which occur only in males, Papa. Huh? Which one? Sorry? I can't hear you. Baldness. Okay. Okay. Yes, there is genetics everywhere. But let's talk of more ominous diseases, where you are asking for that history in the maternal uncle. The child has got a duck-like waddling gait. Child falls frequently when he starts walking. Usually presents when 3 to 4 years of age. Very progressive in nature. Does it ring a bell? Who was the guy who answered that question last time? I owe you a gift which I kept in the car. I said if somebody answers that question, I'm going to give you a gift. Who was that guy? Ali is not come today. The gift is going to be completed. Duchenne. Duchenne's muscular dystrophy is one of the commonest muscular dystrophies in the world. Okay. So that is typically seen in males. Okay. So what is happening is mom is the carrier, but mama is the expressor. So we had one case here in BLDE in the PIC. I'm sure you may not have had an opportunity to see. So that was a child with DMD vectors phenotypes, a PIC only childhood. And you ask the mom and say, did you know that this child had this problem? She said, no, it is there. Every generation there is one child like this in our house. Okay. Now, why this history is important? Why is it important to know this family history? One, if you want to go for a primary prevention level, then you are going to create awareness in the community to declare that when you go to your marriage counselor, I'm not talking of pregnancy, I'm talking of premarital counseling. I'm talking of an ideal world situation. So ideally, people should go to a premarital counselor, which people are doing in Kerala. And the counselor will, may ask all these questions, whether you are having any family history of certain diseases. Especially if it is an area which is endemic for a certain disease. For example, your thalassemia and sickle cell anemia and hemophilia. Very common in certain tribal hamlets where there's a lot of inbreeding. And there are certain belts in India which are endemic for these diseases. So you have got this Nasik and Nagpur, Chota Nagpur, Gond area. Then there are some Sindhi areas. They are more prone to develop your all these hemoglobinopathies. Okay. Agarwals, no offense meant to any community, but you need to know this. Agarwals are more prone to develop. Prone on that does not mean they have to, but that disease is more found in that community because something called as founder mutation. They are more prone to develop a neurological disease called megalencephalic leukoencephalopathy with subcortical cysts. It's called Agarwal's disease. Okay. Vaishya community are known to have cholinesterase deficiency. So anesthetists, before giving anesthesia, they ask this history whether you are a Vaishya. Then they will not use anesthetics which are having this mode of action through the cholinesterase inhibitors. Okay. That is why it is very important to know the family history and the community to know whether this particular disease, even in the Western world, the French Canadian descent, there are certain diseases which are common. The Ashkenazi Jews, there are certain, for example, Tay-Sachs. Tay-Sachs disease is very common in the Ashkenazi Jews, right? And your is all these hemoglobinopathies, they're more common in the Mediterranean belt. Mediterranean will include France and Italy and the part of Europe. There's a belt there, Nice and all that French Riviera. So there, the certain diseases are more common. There's an Amish community in the US, which is a very close community, right? I don't know if any of you have interest in history and in geography. So in the US, they are very close community. They are not mixing with the outside world. They have their own rituals, their own customs, their own in fact, some decades ago, they did not even have electricity in their houses. They would have their own ways of self-sustaining economy. So they are very resistant to vaccinations. So it is very important to know which community they come from because a particular community behaves in a particular way. Okay, behaves in the sense I'm talking of behaviors relating to health or behaviors relating to culture, right? So it's very important to know that so that you understand that, okay, this community, this is likely to be, something that I should think of. So you're actually having dots everywhere and then a clinician connects those dots, right? So you have your name, you have age, you have gender, and then you don't have an occupation. Please don't write that thing in your case sheet. And like you write in your medical case sheet, don't write occupation. And then address. Very important. We've already discussed about how address is important. I've told you what areas of the country can have what. So suppose I have certain areas of the country, for example, in Kerala, there was some areas where a lot of pesticide was used. That has caused a lot of neurological issues. Okay. And then there are some areas where there's a lot of arsenic deposits. So they will have arsenic poisoning. Some areas, for example, there's an area near New York called Bronx. It's a very rundown area, old dilapidated buildings. And those old dilapidated buildings had paint which had lead. Okay, so now lead is banned in paints and in fuels and everything, but still lead is available in the environment. So where is lead available? Lead is available in cheap lipsticks. Okay, lead is available in cheap plastics, especially plastics of yellow color, which are not ISI marked. Okay, and then they are available in half-baked ceramics. So you know you need to go into these details of getting into the bottom of the problem. Suppose a child has come to you with blue stippling of his mucosa, or he has come with chronic abdominal pain, or he is coming with neuropathic features, and he is having refractory anemia, you are suspecting lead poisoning. Okay, so it's very important that you understand this. This is why history is important. You know, have I told you the intriguing story of Professor Jacob John in diagnosing leachy encephalopathy last time? This is where history works. You know, every book will tell you how to take a history, but these are the things that only a clinician will tell you. When your sir will tell you or your teacher will tell you. So what happened was there was a very peculiar incident happening every year in lychee season, lychee harvest season in a place called Muzaffarpur. Okay, in Bihar. So how many of you are from the north here? So you must have heard of that thing, right? Lychee encephalopathy, have you heard of that? No? Okay. So if you have not heard, then hear it from me now. So what is to happen is every year the lychees are harvested. Okay? And around that time, children used to get admitted in the hospital with a strange encephalopathy where they are unresponsive, they may have seizures, and some of them even die. So is it a viral infection? First time it happened, they just thought it was some viral encephalitis. Tried to treat it, some of them survived, some of them didn't survive. Okay. Then when it started happening on a yearly basis, they noticed that it is happening in the lychee season. Now for that you need to have some overview, right? You need to have some overview into what time of the year this is happening. So they noticed that, okay, why is it occurring in the lychee season? What is that? Is it the weather during the lychee season which is causing this, the change in the weather? For example, we have our seasonal flus, right? We have it in a particular weather. We used to have dengue in a particular weather. Now it has become kind of throughout the year. It's endemic. It's not an epidemic anymore. So this was the beginning of the investigation. People did not know what is happening. Then there is this very famous person, Professor Jacob John from CMC Vellore. He is an infectious disease expert, and there's a lot of work in vaccinology, stuff like that. And very great guy. And he came to this Muzaffarpur, and our own pediatric Dr. Arundhati was there. Both of them, they went and they studied and saw what was happening. Look at how history taking at the community level is going to track a disease which was not described so far. So many variables here. So what is to happen is the lychees used to be harvested at around 3 to 4 a.m. in the morning, because lychees by nature are very perishable fruits. They have to be harvested early and they have to be dispatched early. You can't harvest them when the sun is shining bright on your head, and then you lose a lot of time in transit. So what used to happen is parents had to wake up very early in the morning and then go to the lychee orchard and they used to take their children, because they can't leave their children at home, right? Young children at home. So when these children used to go there and these people used to pick up those lychees, there used to be some raw lychees which would fall on the floor, on the farm floor. The children had access to the raw lychees, very raw lychees, whereas the adults were picking up the near ripe ones to be dispatched. So after consumption of this, children started having encephalopathy. Not all of them, some of them. Children started having encephalopathy and then seizures, and then they were taken to the hospital. And some of them had resistant seizures and then encephalopathy, and they deteriorated and they went on ventilator. Some of them survived, some of them didn't survive. Well, so is it something to do with the lychee? Is it something in the lychee that is causing some pesticide in the lychee? They didn't have a clue. Then what happened was, they noticed that these children who are going to the hospital are having hypoglycemia. All of them. All of them are having hypoglycemia. Whoever had this problem and they were brought to hospital, they were having hypoglycemia. Right? So ideally, when a child comes to us with seizure, the protocol is that you must see the random blood sugar. Okay? So what will happen? Sometimes it gets missed in the peripheries and that was not seen. But when they started seeing, then the government made it mandatory that any child who comes with these kind of complaints needs to have a random blood sugar level done. They noticed a pattern. So what are the patterns they noticed? These are the patterns that you must look for. As a doctor, as a physician, you should always look for patterns regarding these. So one pattern is it is occurring in the lychee season. Second pattern is it is having hypoglycemia. Then they looked into the family circumstances, right? Of course, they had a look at the children. So when we are doing a study, suppose I enroll 100 children, then I'll see, okay, what was the weight of these 100 children? What was the height of these 100 children? Were they all having SAM, severe acute malnutrition, or even they were normal children? So we do all these variables, right? So when they did collated all the data, they saw that these children were all malnourished. They were all having SAM. That is the third pattern they are seeing. Okay. What is the fourth pattern that they are seeing? What used to happen is, because these people had to go to the farm at 3-4 a.m. in the morning, they had to sleep early. Okay. So if they had to sleep early, children who are generally fussy eaters would go to bed hungry. So instead of the usual non-lychee season where children used to wake up at, used to be awake until 10 or 11 a.m. at 10 or 11 p.m. at night, because they had to wake up at 2 o'clock and go, people were sleeping at 7 or 8 p.m. 7 or 8 p.m. was not the usual time of these children to have dinner. So they threw a tantrum and they went to bed early without eating anything. So what is the next pattern? They had a baseline extended hypoglycemia. They had reduced glycogen stores because of severe acute malnutrition. And they woke up and went empty stomach and they ate unripe lychees. So right now at this point of time, it's making much sense, right? It didn't make to them also then. Then they examined what is that the unripe lychee is containing that the ripe lychee is not containing. Right? So unripe lychee was having a chemical constituent called NCPG. So this NCPG was the one which was going to induce hypoglycemia in a child who had reduced glucose reserves. So that explained acute encephalitis syndrome due to this cause. It was not a virus. It was selectively targeting undernourished children with reduced glucose reserve who were sleeping empty stomach at night, waking up morning, going and eating unripe lychees, developing hypoglycemia, and hypoglycemia caused uncorrected hypoglycemia, went on to become fatal for that child. So since then, what they started doing is first, the whole public health machinery was put into action. First, short term is see the blood sugar level immediately after the child comes. Give a shot of glucose or dextrose. Okay, and then break the cycle of hypoglycemia. Then treat the rest of the part. All children who received glucose did well. Nobody died. Right? Second, target the reduced glycogen stores. Increase the nutrition level of the children. That's not going to happen overnight. That's a life cycle approach. That's a long-term strategy. Third, instruct parents to feed the children before they go to sleep. Fourth, don't allow them to eat unripe peaches. So, is this possible if you are just doing a CSF test, sending them to a lab, PCR, IgM, IgG, Falana, all those kinds of, very fancy investigations? Did you pick it up? You won. How did they pick it up? History. They picked up with the history. So this is how most diseases are diagnosed, right? So name, age, gender, address. So address is important. Somebody initially, this Japanese encephalitis. It is found in certain pockets. Now it is becoming again endemic because of migration, a lot of migration. So previously, Japanese encephalitis was endemic in Kurnool, Ballari, this area. Okay, so that area was receiving a special allowance of Japanese encephalitis vaccine. It's very important to know, and that this is the part which has got a lot of Japanese encephalitis. So I'm thinking that is the first differential diagnosis when a child from that area. Similarly, you should always know which part of the country there are a lot of migrant laborers. Right? For example, in our state, right now the highest migration is in the region that I stay, Shahpur, Surpur area. Okay, so there is highest migration. A lot of people who migrate during the non-harvest season. The same thing is with Rajasthani families in my area. The Rajasthani families in the non-harvest season, they come from Rajasthan to down south to do carpentry or painting or something for some quick money, and then they go back doing that. So what you need to remember is, now here I am only dealing with people from other states. If you go to other countries, for example, if you go to UK, you are having people who are coming from different countries. So you need to know what's happening in their country to make a diagnosis. For example, if somebody comes with tuberculous meningitis from India, tuberculosis is almost like, in just 1 or 2 cases all over the country in UK. But if it is an Indian or a Pakistani or a Nepali or a a Bangladeshi or a Sri Lankan, then they will think whether this is tuberculosis. Otherwise, there will be other causes of granulomas. It's very important to know the address and the race, because tropical countries have got infectious diseases. Temperate countries have more of immunological and autoimmune diseases. Okay, for example, multiple sclerosis is more common in the temperate world, where the temperature is sub-zero. Whereas in the tropics, multiple sclerosis is not very common. For whatever reason. We don't know why, but this is the pattern. So you are supposed to know this. Yeah? So this is the micromanagement. That is where they are coming from, small villages. And macro management is country level politics. What happens in those countries? Okay, so you don't see dengue and malaria in UK and US. US you may see in some parts, definitely not. Because mosquitoes don't like cold weather. They don't live there. Okay, they live in warm. They are warm people. They are very friendly. They'll bite and kiss you, right? So they are not autistic. They have very good social skills. They'll jump from one person to another. They stay only in the tropical climates. So it is very important to know that. So suppose somebody comes with fever and chills, some travelers come from India and is gone to UK with fever and chills, you will first think whether it is malaria, because he has come from India, but not a native. If a native British guy comes and is having fever with chills, he'll think of other causes of that. Not here. Similarly, Kerala. Kerala, if somebody comes to me with, fever with chills, I will include another differential diagnosis, which is leptospirosis. Common in Kerala because of bathing in open ponds, okay, which may be infested with rats, urine, or stuff like that. So these are the things that you must always keep in mind. So, for example, tapioca. Tapioca causes some kind of cardiomyopathy, right? So you must know what is their pattern, because you know that all Madhus, sorry, no offense, eat coconut oil, which is rich in MCT. So it is protective or it is a lot of fat, I don't know. But you should know the pattern. You have people from Bihar, they eat mustard oil, right? People from nowhere eat palm oil. Okay. So palm oil does not have very high PUFA. That's not good. Right? So it's important to know this. You only know if you know the culture. Right? So that is your address. So chief complaints with duration. It is impossible for me, I think I've already run out of time. It's impossible for me to go into every single detail. You know, for example, this case of stroke, the whole history is entirely different. Case of cerebral palsy, the history is totally different. Headache, the history is totally different. Seizures, so it will like you have to forget every other subject and will only pediatric neurology if I take classes like this. So I'm just giving you a brief overview of how history taking is very important. So I've told you, I mean, I've kind of, made it into a perspective. I know that you've binge watched yesterday night and Sunday morning is not a great time to listen to a neurology topic. I've been fine. I've let some of them sleep without disturbing them. Okay? I can understand. It is not possible, it is just not possible. Everybody has a timeline. And it is possible that the person has got extrasensory perception of listening well when the eyes are closed. Right? I know that some people can have that. So I respect that. I totally respect that without any offense to what you're saying. It doesn't mean that only when your eyes are open, you are respecting me. You may be respecting me with your ears, right? Or with your mind or your inner soul. Who knows? You respect me and you love me, but you don't want to listen to all the crap that I'm telling you. That's fine. You can separate me from neurology. I exist without neurology also. Okay? Just that is some fun intended there. So what I'm trying to tell you is, read books which will tell you about the art of history taking. Every book will say art of history taking, art of history taking, because it is an art. You will not get what you want just like that. You have to tweak and twist and turn and toss, and then the patient will come up with the history that you're asking to ask repeatedly. If the patient is extra intelligent, then it's a challenge. If the patient is extra unintelligent, it is still a challenge. If the patient is very average, it is still a challenge. Okay, there are very few people who will tell you the way you want to listen. So you have to take what you want only after you ask them to speak. Give them a fair chance to speak. Okay, and then take what you want to. For example, if the mother says, my child has cold today and that cold has caused this deviation of the angle of mouth. She may be right, she may be wrong. Okay, so that may have caused ASOM and that may have caused lower motor neuron type of facial palsy. Or it may be beyond that. So whatever the mother thinks may not be relevant. So when I said trivial fall, you remember I told you trivial fall. So when somebody has a fall, you should always ask whether it is trivial trauma or it is impactful trauma. Trivial traumas will trigger certain diseases. For example, even tuberculosis will be triggered by trivial trauma, tuberculosis meningitis. There's something called a subcortical rich focus. Suppose a child has a trivial trauma, the rich focus will suddenly open up and it will cause dissemination of the TB bacilli. That is trivial trauma. But suppose a child has not had an impactful trauma, still the clinical features are out of proportion to the trauma, then you have to think what else this is. So like I said, the mineralizing angiopathy of reticular striate vessels, what happens is, why in infancy? During infancy, those vessels are at a very angulated, fashion. So when there is a fall, there is an acute increase in the angulation and sudden interruption of blood supply, with the background of the child having had some CMV infection or something which is postulated, which causes a little endothelial trauma, and that causes stroke. Okay, so these are all the things that are important for you to ask. So when the child wants a parent, will say, okay, the child fell, but he was okay after a while. But then impactful trauma is the child fell with a thud. You could hear that there is a hematoma there. We got a X-ray or CT scan done, there was a hairline fracture. That's an impactful trauma. Okay, so then you have to differentiate that, especially non-accidental traumas, right? Now these are all medical legal things. So again, history here, that's called safeguarding. So suppose you have a child who is non-mobile and he has got injuries on his body. So always remember, any non-mobile child having injuries on his body is not normal. That is called as non-accidental injury. That means there is a possibility of child abuse. Okay, very important. So especially, and they also have patterns. For example, somebody is holding the child here, over the wrist, over the ankles, so the encircling ecchymosis, or pinch marks, or cigarette stubs. In fact, in Nelson textbook of pediatrics, there is a page which will show you all those types of injuries. Subconscious hemorrhages, bleeding in the falx cerebri because of shaking of the child, right? So this shaken baby syndrome. So all these things will only come with history. Will any parent come and say, doctor, I took my child and shook like this? Will anybody will tell that? No. You need to know what is the family background. A child has come to you, a non-mobile child, 6-month-old child, who has barely learned to sit, not even sitting, and he has come to you with seizures. You do a CT scan. There is a bleed in the falx cerebri, a midline bleed, and he is developmentally normal. You ask what is the family circumstances, what are the things that happen in the house on a daily basis, how is the mother's or the father's mental status, are there any other stressors in the family, what is happening, alcoholism, cigarette abuse, or intimate partner violence, God knows what is happening in the family. It's very important to go to those details. Like I said, it will be impossible for me to tell you each thing, especially seizures. One word of caution for you: whenever you are going to brand something as seizure, you need to get your history very, very, very right. Okay, the best way, there are a lot of things that there are at least 25 questions you have to ask to confirm whether it is a seizure. The best way is to ask the parent to enact that seizure episode if they don't have a video. If they have a video, then nothing like it explains most of the things. Of course, you need to know what happened before and after, and how is the face of the child, how about the eyes of the child, how about the hands, how about the legs, how was the sensorium after that, and how long it took to recover, and who else in the family had, and all that kind of stuff. So it is very important that you ask them to enact if they don't have a video. Or if it is non-serious, then ask them to get a video and come back to you. Don't start a drug right away, because it becomes very difficult to withdraw it later. I know, for many reasons, including medical legal reasons, right? So it is, I am hammering over and over and over again that there is no substitute to good history taking. There's no substitute to the time that you spend with the parent, in spite of all the AI that you have. There may be ChatGPT, there may be that, and there may be this. Your profession will never be threatened. Your identity will never be threatened, and it should not be, because the care that we can deliver as humans, maybe ChatGPT will clear MLE with much better grades than us, but the soft skills, okay, the conversations that we need to know is what is required, not just for diagnosis, but for treatment and prognosis as well. So again, that's a different thing. It's a lifelong journey. You will learn with time how to talk to patients, how to handle patients who are very ruffled and very upset, how to break news of disability, how to break news of death, how to break news of a disease which is not going to be cured, how to develop that sensitivity, how to introduce yourself, how to, break the news in installments rather than in one go, right? How to allow them to, start the healing process, how to help them in accepting the disease, because acceptance is very important of any disease. So these are something that you will learn with time. Don't think that, oh, din bahut dur hai, jab I will do all that. You are already here. You have arrived. So you need to do it today. You need to do it the next time you are seeing a patient. Because you can't develop your skill the day you are a consultant in a tertiary hospital or in a corporate hospital with an AC. No, you will not develop it that day. You are only going to act what you practice all these days. So allow yourself time to read from clinical methods book, which I see, and I'm sure sir agrees with me on that. And everybody is concentrating on MCQs, entrance, and your whatever marrow and drug ladder. Nobody is reading clinical methods, which is a tragedy that is going to be for generations to come. Clinical methods is very, very, very important. What use is your knowledge if you can't translate it into action? Okay, and you need to know how to do it. You don't have to do an ultrasound abdomen to see whether there is hepatosplenomegaly. Okay, you need to see with your hands whether there is hepatosplenomegaly. Right? So develop those kind of skills and be that kind of doctor. Do you have any questions? I think I need to go to clinic now. Yeah. Fine, you can go back to sleep in your room in a different, take off your apron then. Yeah, I'm not mocking you. I totally understand because you have other subjects to read also. It is not clear, it's not the only thing. But I appreciate you coming on a Sunday morning and spending your time. I'm sure. So no questions? Sabha barkhast kiya jaye. Right. Over to Rajesh sir.
One. Whoever have come there must have been immensely benefited by your work. A very nice thing to man. What I believe in a teacher who cannot explain the things in a simple way has not understood himself. Whatever subject is. That's very true. Like the way ma'am simplified everything. Even the most lengthy diagnosis she simplified very easy to understand. It was very nice lecture, ma'am. Thank you. Thank you.
Thank you. Right, thank you. Your attendance will be taken by Giresh. Yeah, you can close the. There are some students who have there in the online mode also. Akansha, do you have any questions to ask? You can unmute yourself. Are you there?
No, ma'am. No questions. Thank you so much for the session, ma'am.
Okay.
Your sense of humor was like an icing on top of everything, all the information that you gave us.
So you only had the icing or you had the cake also?
Yeah, we had the cake also.
Right. Right. Thank you so much, Akansha.
Thank you, ma'am.
Right. Okay, guys, then have a great day. No more questions from your end. At Ali, I'm going to take back that gift because they have not come. Last time, what happened was we had two cases, and the case that I discussed had a sibling who was sitting there, and I had not told anything about that sibling. So I asked in the class, can anybody pick up something that I have not discussed or told in the class? So that guy had picked up that the sibling also looks developmentally delayed. So I said, I'll give him a gift. But I went to the clinic. Okay, thanks guys then. Back to your pavilion, study well. When are you appearing for your